Good afternoon, everyone. Good afternoon. Please take a break from your conversations, and we'd like to say welcome back. Thanks for sticking here through to the end, and it looks like the crowd is absolutely fantastic. How's the food, everybody? We do okay? Yeah, the food is great. So we're going to go ahead to our keynote speaker, and we're really excited to have Larry here. Larry has come to us from Stillwater Medical Group. There's something about the water in Minnesota, I think, where they're kindred spirits to Oregon in many ways and perhaps leading in the arena of patient experience and I would say transparency as well. We're fortunate to have Larry with us. He's had a tremendous amount of experience in using patient experience data and improving patient experience data. Larry is actually the chair of the Minnesota Shared Decision-Making Collaborative, which I know is one of his very big passions. He's working to support and improve patient experience through a number of clinical implementation projects and research. Larry's a strong believer in teamwork and that working as a team we can find the best solutions, both for caring for our patients as individuals and for caring and improving systems in general. So with that, I'd like to welcome Larry Morrissey.
Thank you. Thank you. Appreciate the opportunity to come talk to all of you today. It's really exciting for me to talk about something that I care about very deeply. And I think one of the things I'd want to sort of start out with is just letting you know a little bit about Stillwater. It's a small town just a little bit outside of the Twin Cities. Dale and I are both from Stillwater, and we'll tell you that Stillwater was there first, and then these other towns called Minneapolis and St. Paul, they came later. Stillwater, there was a decision to be made back in the 1800s, and one city was going to get the capital, and the other city was going to get the prison. St. Paul got the capital, Stillwater got the prison. We think we got the better deal. When I went, my grandmother was actually a warden at a prison, a women's penitentiary. And when I got my job and I told her where I was working, she goes, "That's a good town, there's a good prison there." And so a little bit about where I work, so you kind of understand that part. So in this story that I'm going to tell you, Stillwater Medical Group started out at the beginning as sort of a classic physician-owned practice. We were about 45, 50 providers. We owned our own group. We set our own agenda. We haggled over the compensation formula endlessly. And we all thought we were doing great. But we realized that in the grand scheme of things, change was a-coming, and that's kind of the theme for today. And a lot of change has happened over the last 10 years. And as we went through that process, we've grown quite a bit. We're now about twice the size what we were before. We're now part of an ACO. And we're a real multi-specialty organization that really does provide kind of all the levels of care that the patients in our community could ask for. Because the folks from Stillwater don't want to schlep all the way over to St. Paul unless they have to, because it's like 15 miles, and that's like way too far. And a little bit about me. I started out this process as a general pediatrician. I was young. I'd been in the practice for a few years. I was kind of enthusiastic. They thought they'd take advantage of that and the fact that I was sort of gullible and say, "Hey, Larry, you want to do some administrative work?" So I wound up becoming the medical director of quality improvement. And the fun part about that for me was that as a job, I recognized the opportunity to be able to set the agenda for the organization in some ways. And there were two things that I looked at in our organization that I really felt needed change. One was we were very reactive. Someone would come to us with something like a quality number and say, "You're doing a really bad job in this, go fix it." But we weren't looking ahead to see what the next thing was. We were always kind of behind the 8 ball. And the other piece was that, a lot of what we focused on was not about the patient. It was about diabetes numbers and other things, and it didn't really feel like it engaged people. And so I got the chance, and I'm going to tell you a little bit about how, to sort of reshape that agenda for our organization and change our culture to be more patient-centered. And I want to talk with you a little bit about how we went about doing that, the role that experience surveying played in that process. But keep in mind as I'm telling you this story that it's about the journey, not about where you end up. And there's ups and there's downs, but it's a great journey, and going on it is worthwhile. Also, I promise, if anything else, you will get to see lots of pictures of vacations. So that's my kids up in Rossport, Canada, at a really great hotel that used to be a train station. So what we're going to try to do today, I'm going to try to help you understand how to begin working within your organization to improve patient experience. I want you to be able to come out of this understanding the difference between patient experience and patient satisfaction. You've been hearing about that all day, but these critical elements of how these surveys are different than what maybe other people have done. And then here are some specific examples of things that you can do. But it's really that first one, how do you look at taking this journey, that I want you to think about. So this is the Baptism River up on the north shore of Lake Superior. And our journey started as a QI project. There's this quality improvement organization in Minnesota called ICSI. I was the QI director. ICSI put out projects. We've done a project on the PAM. Somebody asked a question about the PAM earlier. We did a project about diabetes care. We do all kinds of things. And they said, hey, we're going to do one on patient experience survey. And so we started by doing a pilot implementation back in 2004 of the CAP survey. And when we went to meet with the experts, there was this guy in the room named Dale who walked up to me and said, Larry, I'm really invested in your clinic doing well in this project. And I said, well, why is that? He goes, because I go to your clinic. I'm like, okay, we got the expert with us. But we did some things in that process that really helped us learn a little bit about this. And I'm going to talk about some of the learnings that we had. But our basic strategy was like any other QI thing. We measured, we looked at the results, we planned an intervention, and then we measured again to see how we did. Not rocket science. We were in the process at that time of really looking at how our organization was functioning as a culture. And it was this sort of crucible of thought about how are we working together as a group? How are we going to tackle the problems that we have in front of us and change from being this physician-owned group to something better? And in that process, one of the things that was happening is we recognized that in order to be more successful and get things like an EMR and a better building, we needed to integrate with the hospital in order to achieve our goals. And so these are the kinds of things that were happening when we started. And this is the results of our first survey. And you don't need a lot of detail here, but the basic idea is that the up and down axis is how well we did. And we did pretty good on things like access to care, actually. And then the side-to-side axis was how much it mattered to our patients. And the thing that we recognized was that communication was the thing that mattered most to our patients, and we were just around average with that. And so that's the thing that we chose to focus on, because it was important to them. And in this process, one of the things that we did was we did some focus groups to dive a little deeper and understand what the patients felt. Now, my personal computer is kind of like an episode of Hoarders, because I never delete anything. And I'm digging around in there to make this presentation, and I actually found the slides from the focus groups that we did and pulled this quote out of the slides, because I remembered this quote. It made such an impact on me. This was one of our patients talking about the relationship he had with his providers. And I'm not going to read it all to you, but the idea that their demeanor allowed him to be open and have this trusting relationship. And it didn't matter how much time, it was how you interacted with me. That was really important. But this wasn't the part of the statement that was compelling. When we put this up in front of our board of directors, the thing that lit a fire under people was the sentence that came after this one, which said, when I don't go to see one of these two doctors, when I get the doc of the day, it's nothing like this, and I have a bad experience. And that was a powerful thing, because we wanted everybody to have this kind of experience every time, and that this person recognized that it wasn't consistent was a motivator for us. And so we realized that patient experience was very important for us to be successful as an organization. And that physician communication was a key part of the patient's perception of that. And we began, that was our first sort of entree into doing things like a patient advisory panel. This is in 2004. The idea after those focus groups of having those people come back and be a patient advisory council was brought up. It took like 6 years before we actually executed it, because we're not exactly fast at things. But it brought these ideas to the table, helped people think about things. But one of the things that we learned was that the one-time intervention wasn't the right strategy to deal with this problem. So we brought this guy, expert, in from the outside, and we brought all the providers in the whole group through a one-day patient communication class. We did role playing, the whole 9 yards. The guy wore, and I'm not joking, it looked like this necklace. And he had this long flowing white hair. It looked like hippie. He was from Maine. But, so, he's from Maine. I'm giving too much away now. But, and when everybody filled out the forms, you know, the little how is the speaker thing, everybody's like, oh, he was great. Good job, Larry, that was wonderful. You know, the board was like, Larry, this was a very good job, it was a great project. And actually our data got better. Our numbers improved in the couple months afterwards. But then, very gradually, the conversations in the hallway turned to jokes about the guy with the necklace. And I knew that we hadn't really gotten where we needed to be, because everybody thought, no, it's not me, it's the other person. I'm not the one with the problem, and I can kind of go back to doing whatever I was doing before. And it was hard to get people to change, because the culture didn't support the individuals doing the right thing. And so we had to kind of learn from that and move on. It's kind of the theme. So one of the things that we did was we went back and looked at what's the case for doing this. And you've heard today already, and this, they didn't see this slide, but one of the biggest things about this is looking at this kind of information is the right thing to do, because we want this for the people we serve. People in healthcare went into it to help other people. That's why you do this job, which makes you work 90 hours a week. You don't want to be up at 3 in the morning just because. They can't pay me enough to go in the hospital at 3 in the morning. It's the right thing to do, and people can connect with that. And there's also, for the administrative people, a really strong business case that if we give good service to our customers, they're going to recommend us to the next person. And that word of mouth is powerful. It matches our other organizational priorities. And in order to be successful, we do have to measure what's important to us. And as we sat at a board and we said, okay, how are we going to get at this? We looked at those compelling reasons, and that allowed the very senior leaders in the organization to say, this is part of our agenda. This is a high priority. And one of the key lessons here is you've got to have that senior leadership buy-in in your organization, or you're going to get shot down eventually. And you've got to work on changing the culture. Because you have this good thing. Everybody likes that, right? You know, patient experience. It tastes good, and it makes our patients happy. But people's habits and the everyday grind of the work that they have to do is kind of like the Cookie Monster. And it just takes it away. And then Elizabeth's not so happy anymore. And this is a quote that was from a slide that that the president of the clinic put up when we were doing one of these meetings about this. And I've kept this for these 10 years because I think this quote is so great. And you really have to have passion about it. You have to be persistent. And you have to realize there's only so much you can do. Take a baby step, one thing at a time. And the interesting thing and this is a long time ago, and sometimes you're smarter than you think you are, but I stood up at one of these culture meetings, and I talked about the fact that isn't this change that we're trying to do organizationally with our healthcare delivery system and the people who work within it, this adaptive change for those people who read, you know, organizational theory books, isn't this the kind of work we really want to be doing with our patients? Don't we want to be helping them work through the adaptive changes that they face? Well, yes, Ronald Heifetz, who came up with that term, is a psychiatrist. It came from psychology to business. It needs to go back. And as a leader, you can generate a signal to say to people, this is important. And if you bring out that signal to go, people are going to respond to it. If you kind of come in with, oh, I don't know, they're going to go, I'm not going to bother with this. And I think the patients can sense that. If they recognize that their experience is important to you, they're going to buy in. Their engagement is important to you, they're going to buy in. So part 2 of the journey. So now we kind of fast forward to 2007. I'm grinding away at the diabetes numbers still as quality improvement director. And we're starting to make some progress. And the people at Minnesota Community Measurement call and say, hey, we want to do a pilot with this patient experience surveying. And we know you tried it out before. You want to try? And of course they ask me because they know I'm going to say yes, because I'll do anything. And so we fielded the next round, and we're very much in the place where you guys are right now. About 9 clinics, I think, 9 medical groups. We threw it out in the water. We haggled over what the questions would look like. We argued a lot about the visit versus the year-long version. And we ended up posting this and putting out publicly, and we all looked at it. Whether or not anybody else did, I don't know. But my boss looked at it. And we thought, we're still at our medical group. We're awesome. We're going to crush this baby. And we were average. And he didn't like being average and said, well, I want to be above average. Let's do something about this. And so we took that next step that many of the people in this room are contemplating right now. We said, if we're going to do this, let's do this well. And we set up a process to put the CAP surveys in place where we were getting 60 completed surveys per provider per year. So it was a statistically valid, on an individual level sample that we could try to use to drive improvement. And we paid for it out of our own pocket because I had that senior leader say, I care about this. And at that same time, the other thing that was happening was this merged clinic and hospital were kind of trying to make sure our vision and priorities were in the right place. And so we were doing this kind of larger scale project about being patient-centered. I'm going to jump, I know I'm making you dizzy with changing slides all the time. So this little circle thing in the middle here came from that. And the hospital was in the process of implementing the HCAP survey. And we went around to the patients, the providers, the nurses, everybody down to the people who clean the rooms and said, what does patient-centered care mean to you? And how are we going to get there? How are we going to give people a good experience? And what can you do to make that better? And it created a different environment where now this is supported and it's an organizational priority. And people wanted to get to that goal. It was good that we had that in place because the storm was a-comin', called Epic. And we have this problem. We're like chronic EMR changers. You know, we're actually on our third EMR now. We started with one called NextGen, and then we switched over to a version of Epic, and then we've switched over to a different version of Epic. And so that was very interesting because I was really afraid because the second round of patient experience surveying for the Minnesota pilot was going to happen while we were implementing Epic. And I'm just like, please, not May, any other month but then. But you know what happened, which was really kind of cool? We actually did better. And I think we did better because we had poor access, but the docs had a lot more time because they were getting these blocked out schedules and they were aware of the computer. And our scores actually went up. So you never know what's going to happen. But one of the things we learned about was there was a lot of variability when we looked at how the individual providers scored. When we got down to that level of detail, we exposed the variation. And that is, for those of us who wear the quality improvement hat, there's the golden moment. Variation, narrow it, make things better, move the bar. And some of the people, certain people who are national experts and come give talks in Oregon, did not really as well as he thought he was going to do. And it was disheartening. As someone who did poorly, I was upset. I was mad at that stupid quality improvement guy who put the surveys out. He's an idiot. I'm a nice guy. My patients like me. But what happened was that we were, in kind of an overall sense, still around average, but we did get better. And I think one of the things that we saw was that after that initial reaction, people started to process things more and think about how can we more effectively go about making these changes. And so we come to lesson 2. There we go. One of the things we thought about in this situation was that we had really worked hard on, with our diabetes data, being very transparent. And this is a caution for all of you, but we looked at this and we had this individual physician data and we thought, hey, maybe we'll roll this stuff out to people. And it was not a wise decision. Because even though this transparency was something that people were used to, I'm going to show you we didn't have any pictures, but this is an artist's sketch of the provider meeting. And what I think happened was that we kind of touched a nerve when we got that individual data out to people, because the people who thought they were doing really well and weren't were really threatened. And I think it's really important to be aware of. It's easier to do this at a clinic level and deal with it's that guy that's the problem, not me, issue. It's a little harder when you take it up that next notch and say, this is how you're doing. Because it requires people to be willing to look in the mirror about something that's very important to them and something that's very personal. And there are still people who are ticked off at me. My best friend, I could not tell him where I was going because he gets mad that I go and do these talks because he thinks this is stupid. Really. So we made another adjustment in our approach. And we leveraged the fact that the new EHR, gave us a different way to make change. And we tried to sort of portage around the waterfalls. This is a waterfall that's sort of upstream from that previous picture. One of the things that, and I'm going to show you some specific examples, but we took advantage of the fact that our hospital decided to become aligned with Health Partners for the ACO thing. And that gave us some opportunities to try some different interventions. And of course, when we switched to Health Partners, we had to change the EHR again. So this is just review, because you've heard this, we've beaten this into you in the course of the day already. But the key part here is that we're looking at specific, actionable, understandable, objective things that people can do in interacting with other people. And that's stuff that you can change. I can't change whether or not you like me. I hope you like me. I am really nice. But I can't do that differently. But what I can do is I can make PowerPoint slides that have fewer words on them and more pictures, because you'll learn more that way. And you'll remember the picture of Elizabeth with the cookies. So one example, and we talked about this a little bit this morning, but there's a question on there about giving easy to understand instructions to your patients. And this is strongly correlated with good overall rating scores and willing to recommend as a positive thing. And we actually had enough data that we could look and see what things people did made a difference in the rate doctor score overall, and tried to focus on those things. And the great part was that we needed to work on this AVS business anyway, because we wanted the meaningful use to cha-ching, right? So it's like Reese's peanut butter cups, you know. That works. And it was easy to start because the AVS system was ready to go. And all we had to do was collect that data and look at it in relation to the patient experience data and see, is it making a difference? Now, getting providers to use an EHR, that is always a challenge. And so this was not really a pilot. That's a misnomer on the slide. Internal medicine department, where the guy who was leading the EHR implementation was housed, was a hotbed of EHR compliance, mostly because Andy was standing right there next to his 6 partners going, use the AVS. Family practice upstairs was not a hotbed of EHR compliance. And as you can see in the AVS use percentage, not many people were actually bothering with it because they just wanted to get out of there as fast as possible. But what we saw when we just took advantage of the fact that we were collecting these 2 pieces of information at the same time is that the family practice department, the score on the question was fairly stable. But in the internal medicine department, when they used the AVS, it went up. We're like, hey, maybe we should get everybody to try this. We realized that that barrier of consistently using the tool was going to be a problem, and we worked on making the information easier to put in there. We worked on making it easier to get it to the patient. And we sought out those early adopters and had them tell the stories of how this made my visit better. And telling a good story is a powerful tool to get people to change. Thus, I'm in Oregon. And so when we did that, the rate of the AVS use went up. And there was a pretty good correlation between when somebody gave an AVS and the score on the question. Yay! Right? So this is post-intervention, and now the family practice is using it, and the Vikings are in the playoffs. And with our, I think they won as many games as the Seahawks did. Is that right? Ooh, that was a shot. What's important here is that, and why I put up this slide is that we thought we were there, but we weren't. Because there's a lot of things that can affect the scores on these questions. And as you can see in this chart, how well you do when you track it over time is very volatile. So you have these dips and improvements and different things that you can't control sometimes that are going to affect the outcomes of these questions. And it makes it a little bit more challenging to do this work than something like the diabetes work, where a lot of times once you get stuff in place a little better, it stays a little more stable. So we're not always really there yet. And we still have to grind and work on it and try to make it better all the time. Another example that I give for people is this concept of shadow coaching. I went through this myself. It is a program that Health Partners has that a non-physician goes in the room with you for a whole day and watches you work. And they have specific things that they're looking for to see what you're doing. And then they give you feedback in a structured way that's not threatening, that helps you understand what things maybe you could change that you could do better. And they do measurement and look and see how well you improve. And it's actually kind of a separate set of measurement from the CAP survey, but a lot of it aligns pretty closely. When I did the shadow coaching, one example of what the coach taught me was that I, for years, at the end of the visit, closed with the phrase, "Do you have any other questions?" Pretty reasonable thing to say, right? And some docs would fear that because it brings back out the laundry list. But I've never been afraid. I'm a pediatrician. I like the laundry list, because if I get the laundry list done at the 2-week check, then for the next 3 babies, I don't have to go over it over and over again. And so I liked to answer those questions. And I thought I was inviting the patient to do that. And he said, "Do you realize that you're not inviting them to participate in the conversation, you're shutting them out?" And I said, "What do you mean?" And he said, "When you say, 'Do you have any other questions?' your body language says, 'I'm going to get up out of this chair and leave.' And when you use the word 'other,' that means all of the previous questions that you asked are done. They're no longer part of this conversation." And I thought, well, that's not what I meant at all. And it really helped me to have that other set of eyes look at what I was doing and say, wow, can we do things differently? So does that take the form of the secret shopper, where you have somebody who's not a part of your site walk through the building and look at all the stuff all the clutter that needs to be cleaned up in the waiting room? Or does that take the form of a peer talking with another peer about what things do you do that work well, that get patients to talk more? Those specific behaviors are things that you can change. And there's a pretty consistent, in this program, improvement in overall scores amongst the people who do it. And it sustains itself better than the intervention that we did before, talked about earlier. And when I gave this talk to the people in Seattle, they actually wanted a whole separate hour on the shadow coaching, because it's a really good program. The challenge with it is it's a lot of infrastructure to build. It's work to do, and that's going to be a choice that you have to make as an organization. But don't be afraid of the shadow. It's a groundhog, folks. When I made this slide from Cheryl, who runs the shadow coaching program, I took her slides and then I made this slide, and she goes, "I want to steal your groundhog." I'm like, that's fine. I got it off of Google. So some things for you to think about. It's hard to maintain performance. And results are going to vary, but variation is good. Because variation helps us learn. Variation is what helps us get better. Embrace that. Embrace the fact that this is complicated work. Because you want to take care of the easy stuff to get people confidence, but you also have to have the courage to take on the stuff that's hard. And this may be a tough sell when you try to go back to your group, But if you are selling it because we're doing the right thing here, that's something that people are going to connect with. And that's something that we're going to be able to do things that are worthwhile. I have to tell you, when you guys were having the conversation earlier this morning with Jim about the patient engagement piece, I was like trying so hard not to leap out of my chair, because I do a lot of research around shared decision making. And I spend a lot of time on it. And there's a small group of people across the world who are really passionate about it, who will tell you we do this really poorly. We are not good teachers. The healthcare system does not educate people well at all. But we do have very well studied ways, of better communication of information to patients. There are 86 randomized controls trials that show that decision aids help patients become more knowledgeable and more engaged in their care. Yet they're not implemented anywhere in real life practically. How many randomized controlled trials are there that show that cardiac stents help people live longer? 0. How much money do we spend on that? And there's somebody else asked earlier about the PAM. So I do this patient shared decision-making stuff, and oh good, I have lots of time to talk. I haven't even used up all my time yet. I do this shared decision-making stuff, and I had done some work with Judy with the PAM in the past, and so I'm at this conference in Washington talking about shared decision-making, and I go chatting with Judy, you know, we're just catching up, and she goes, you know, Larry, you were gonna do that research where you looked to see if you could change the PAM scores with the paired shared decision making. Did you do that yet? And I go, nah, I'm trying. I've just got a lot to do. And she goes, and if you guys, how many people here know Judy? Okay, it's kind of Mutt and Jeff because Judy's about this tall, right? And Judy looks up at me and she goes, Larry, you need to do that. And it was like, okay, Mom, I'll do it. But it's really important because I think, and this is just my own personal opinion, that doing shared decision making and understanding that part of it is going to be the pathway to getting patients engaged. And that pathway starts with a relationship that's based on trust, where people feel they're heard. And that's what these patient experience surveys are trying to measure. And one of the things that we've noticed, and this is another paper that Dale is bugging me because I need to write, but when we've measured it and you ask patients their experience in a specific context of a medical decision, so not did my provider listen to me today, did my provider listen to me about my BPH today, the scores go way down. Because these scores, these CAP scores are a little bit artificially elevated, I think, because we're asking in general and not giving people enough context. But the reality is that I think a lot of people don't feel heard. And there is a great paper written by Glenn Elwyn and Al Mulley, published by the King's Fund, about patient preference misdiagnosis, called Do Patient Preferences Matter? And we need to listen to what's important to our patients in order to be able to do the work we need to do with them. And I think the first step in the process is getting this kind of surveying infrastructure and approach to patient-centeredness built in your organizations. I will tell you, I'm having a hard time cracking the nut of doing shared decision-making. And I've been doing this for a while with a group of people who are really motivated. It's not easy to get patients engaged. But that's step Q. You got to go from A to B first. And the start is to understand, how are we doing this? How are we relating to people? And if we do that well, the bottom bullet point's probably the most important one. Because I'm an idiot who just thought this up and did it just because I cared about it. And if I can do it, you all are smart enough to do it. You just got to want to, because it's important to you. And so you're going to go on this journey. Now, this is another vacation photo. This is actually at Disney World. And it's kind of the closing comment. So I took my family to Disney World, and we go by this ride called, in the Animal Kingdom, called the Cali River Rapids. And it's a water ride. And the kids are like, Dad, we want to go on Cali River Rapids. And I'm like thinking, I don't want to get wet. I don't, you know, we got a long day ahead of us. Let's go to the bird show. Because the bird show is right next to Cali River Rapids. And all these other people are walking out of this ride all wet. And I'm thinking, you know, we're going to the bird show. Because I get to be paternalistic because I'm dad. It's part of the contract, you know. So we go to the bird show. And when Dad leaves, because I had to go back to work to pay for the trip for Disney, the very first thing that my wife and kids did was go back to Animal Kingdom and go on that ride. And they had a great time. And the moral of the story is we can have our own perceptions of what the right thing is to do. Unless we ask and listen to the other people involved, we can't really know what the right answer is. And as important as anything is we can't be afraid. It's pretty easy to walk out of here today and say, well, I don't think we could really do that. We got a lot of other stuff on our plate. You know, this is just one thing, and how important is it really? And, you know, we got to balance the budget and argue all this other stuff. This is important. Don't be afraid to go on the ride, because it's fun. It doesn't, you get wet. I've gotten more wet than anybody, I think, because I've screwed more stuff up than you can count. But it's fun, and it's good work to do. And so I'd encourage you all to think about doing it. And with that, I'll stop yapping and answer questions.
So we do have almost 15 minutes for questions. Well played. What do you want to know from Larry?
I didn't even use my timer. I forgot to press the button.
I'm curious why pediatrics is leading in patient experience. That's been said a couple times, and I would just like to know.
I could give some self-serving answers on that. But I do think there's one piece of it that I think does make a difference in that, and it kind of actually, there's another thing, Jim, I'll disagree with you on, and that's the difference between the 90-year-old person with the Alzheimer's and, because 2-year-olds, teenagers, and your elderly parents, there's a lot of similarities too. I mean, my dad is a good example, but we won't go there. But I think part of what, as pediatricians, there's this, we're going to try this. The one person, when we were doing this merger, he said, I'm glad there are pediatricians on this board because they'll go along, they'll try things. They'll go along with it. And they're not going to be so skeptical. But the other part is that our interactions with the patient necessitate getting everybody involved. Because we can't see the whole picture just by talking to the patient. If I have a 10-month-old baby who's sitting in my office, there's a certain point at which I can just look at that baby and know that that baby's sick or not. But most of the information about that baby, the baby's not going to tell me. I got to get it from other people. I've got to elicit and listen to understand, because they're not going to offer it up. And you always have the positive Nintendo sign that you know the kid's ready to go home from the hospital when they're playing video games. But for the most part, you really have to work hard to get that conversation going, and you have to listen, because if you've got a mom who's got a new baby and they're scared and they're nervous and you push them off, they ain't coming back. And when I first started working, one of the first things I did was I demanded that my partners give me 40 minutes with every new mom so I could just get to know that person. And they were like, okay, that's fine, you can do that, it's your money. But it was worth it. I was less productive, but it was worth it because we built that relationship, and I think that's a part. Pediatrics doesn't get enough credit for being good at quality improvement and being good at that. One thing I want to tie, not everybody saw this, but I'm just going to say something too about this. Dale mentioned the maintenance of certification. Our group did an MOC4 that got approved and we all got credit for on this AVS project. So we see the multitasking, because now that was one less thing we had to do. We just all chipped in enough money to send to pay for the application. It was like $75 a person, and wrote out the application, got it approved, and like 20 people called me and said, can I do your project? And when I told them what it entailed, they said, oh, I don't think I can do that. So. Yeah, once you start me talking, I don't shut up very much.
So I'm interested in the shared decision making and kind of what techniques you made or used to engage the patient. Mm-hmm. And things that come to my mind are the Ask Me 3 and the Teach Back. Did you have any experience with those, and how did those work for you?
We do have experience with those things. I'll just kind of briefly describe some of the things that we do. One of the things that's really important in understanding shared decision making is that you've got to start by having the information flow to the patient more effectively. So we've implemented processes that get decision aids with structured educational interventions into the hands of patients before they're making the decision. So we take the pressure off. So if you've got prostate cancer, when your biopsy is positive, it's going to be 2 weeks before you make a decision about what you're going to do, and we're going to give you homework. We're going to have a nurse coach work with you prior to meeting with the urologist. And we have the world's most wonderful urologist who actually doesn't want to operate on everybody and is willing to let patients say what they want. And then when he loved it, this was one of the best phone calls ever, right? It was a voicemail. He says it was an email, but I know it was a voicemail. So I put this shared decision-making process in place, and the urologist said, I'll try it, Larry, I'll go along with you. And it was about 2 weeks in, and I get this voicemail. It says, from Tom Stormont, and I'm thinking, great, he's going to bail on me, right? And he goes, Larry, this shared decision-making is amazing. The conversations I'm having with the patients have completely changed, because now they come in understanding what's going on so that we can have a conversation about what they actually want to do and not spend all this time me telling them about things that they're not interested in. And the great part is that it's making me more efficient. I'm getting out of the room faster because now we're spending our time talking about what matters to them and not all the things I think I'm supposed to tell them. So that exchange, moving it upstream, is even better than Teach Back, because Teach Back's an endpoint. Get the information up there in front, and you don't need Teach Back because they told you what they know. Moving this upstream is my kind of theme in shared decision making, and the people in the community kind of argue with me about it, but I think that's huge and critical to our success. We are right now in the process of trying to, literally started last Monday, doing this with PSA testing in men. And I'm really going to be interested to see how our little audacious internal medicine department feels about getting that information to the patient prior to their preventive services visit so they can have a conversation about whether or not to do PSA testing. And that's going to be a really exciting thing, I think. Dale mentioned Align. I've been working with Align on a project like this for colon cancer screening, and it's actually going quite well. So there's a lot going on in that area, and hopefully we're going to be able to figure it out. But it's challenging work.
Can you show us a couple of examples of the NAVACE tool? Because it seems like that's one of your secrets of success.
Well, it's not really that complicated, actually. Our version of Epic has a spot where this pre-structured information that the patient is supposed to get is all printed out. So it's got their allergies, the diagnosis from the day, the person they saw, this basic information that people are supposed to be able to reference when they go home from the visit. And what we did was we built little dot phrases that people can drop into that space of the information that they want. And some of the providers print it out and handwrite it on there, but most of the time people have gotten to the place where it's kind of typed up in there, so it's all part of the record. But the important part of that tool is that it takes people time to process this information. I went to school for a long time to learn this stuff. I can process it faster. There's plenty of studies that show if you gave somebody a quiz of what happened in the office, the score is like 50% by the time they get to the waiting room and 30% by the time they get in their car. People can't hold on to all that information, and you've got to give them tools that say, here's what you can reference back. And so people like UCSF and the breast care center there are doing things like taping the visit so the patient can go back and listen to it again. That's a great tool to help people retain the information we're trying to give them so that they can think about it and understand it, because it takes everybody time to learn it. You said you were an accountant. I always joke, I don't want to know anything about my 401k, because I would put it all in the mattress, because I don't understand any of that, and my wife won't let me look at it, because I always say, we're going to lose all our money because the stock market's going to... She says, shut up. This is my job. So, but it's important. It's hard to understand this stuff. It's complicated material, and giving something to a person that they can reference really helps.
One of the Patient Family Advisory Council major projects has been to promote the use of the AVS. One of the driving forces was when you go home, your spouse says, what did the doctor say? The answer now is, here's my AVS. But what I wanted to share with you, we also are trying to improve the process. We have developed a agenda setting form. So what the receptionist hands you a clipboard and a form and asks you to say, what are the issues you want to discuss with the doctor? What changes have occurred? These sort of things, so that the patient enters setting the agenda in terms of what their concerns are. And that seems to really have made a big impact.
Yeah, it's a great point. It is another thing that we've done, actually. I mean, I got a whole laundry list of things that we've tried. But one of the things that's really funny about that is the degree of arguments between the different departments about how many bullets, like 1, 2, 3, 4, how many lines, how much space. And so it's kind of funny because when you look at our agenda setting form, it says, what's the main reason for you here? And there's a box. And then what other things might you want to address if there's time? The if there's time was a concession to the family practice department. And then there's a spot for provider notes. Now we've been magnanimous enough now that we've actually, the size of those two sections, the patient notes and the provider notes, are actually the same size. In years past, the patient part was like this big and the provider part was like that big. But I think agenda setting is a really great tool that can help people feel heard. Because even if the answer is, I don't have enough time to talk about this today, we're going to have to deal with that later, at least you heard what I had to say. And that's critical.
One of the things was to eliminate the, as you go to the door, oh, by the way.
Yeah.
One
last
audience question.
Hi, I'm wondering if you can talk about the relationship of the use of the PAM and how it relates to the patient experience.
You know, when we piloted using the PAM, it was very exciting in a way, because it gave us a lot of good information about kind of where our patients were at, but people really struggled with how to use that information. And I think it's a question without an answer right now. It's a research project begging to be done, because how we take this piece of information about the degree to which the patient is engaged and find a way to move that to a place that we know is better in an effective manner is something that, you know, is still an open question. And I have tried to incorporate measurement of PAM into some of our shared decision-making things, but it was difficult to do because some of the staff people kind of resisted it, which I thought was kind of interesting.
Okay. I have one more question before we let you go.
Okay.
The moderator's prerogative. You mentioned a couple times in your presentation the public reporting aspect in Minnesota.
Mm-hmm.
And I'd like to know how, if any, in any ways that helped your organization engage around patient experience and the culture change. Was that helpful? Did it get in the way? Was it a distraction?
Okay. Is the answer can stay in this room? Please. I think it really, public reporting lights a fire under CEOs more than anybody else. And public reporting, motivating senior leadership to make sure that you have the resources you need to make it better. As long as you actually make it better when you use up those resources, is really a helpful trigger here. I know that a lot of other people look at public reporting as a way to motivate patients. I've never really been completely convinced of that. I think a small number of really educated people may be motivated and switch doctors because somebody has a better score. But a lot of times it's really the relationship that drives which person you're going to go see and the experience that you have. And what public reporting does is gives you a sense of where you are in relation to everybody else. And so it worked great for us with diabetes because we needed to fix our processes because our processes were broken. And we took our number. When I started as QI director, we were 49th out of 50 and at 5%. And when I finished as QI director, because I quit because it was burning me out, and I wanted to spend time doing this, because I like this, we were above average at like 45%. And we climbed that mountain in part because we had the backing of and the support of the people in the administration who needed to say, you have permission to go forward and do this. And also we built the infrastructure to be able to do it successfully. And that meant investment of time and money. And I think that's what public reporting can do. I'd argue, and this was an accident that this is sort of a watercraft, but my viewpoint is that for us to really genuinely be successful as a society, we've got to look at things that lift all the boats. If we are so competitive that all we're trying to do is beat each other, we're never really going to get anywhere. And public reporting has a lot of potential to lift all the boats if we use it the right way, as a way for people to understand where they are and understand that they can get better. Because our clinic's going to be better at thing A and your clinic's going to be better at thing B. And I can learn as much from you as you can learn from me. And if we can change the mentality and move it away from this competitive public reporting to public reporting for the purposes of making the community a better place, that's going to move us a long way towards all of our goals.
Thank you.